Good evening, everyone. I am Arsham. I am joined by Dr. Sahar Bedrood and Dr. Christine Funke here. And actually, I'll give just a brief intro about myself and have our other two moderators and panelists talk too. I am at Washington University. I do glaucoma and anterior segment. We have been using iTrack, which is what we're going to be specifically talking about, and more kind of some physiologic concepts with the catheter, but we've been using iTrack for the past several years. I do think we all kind of know the advantages with the catheter and the light mechanism and how easily it loves to find its way into the canal. But we'll introduce some alternate concepts. It's not been anything that's been like a change in the actual device itself, but some other concepts that we think are probably pretty important, hopefully in the long run for treating glaucoma. So I will let Dr. Bedrood introduce herself and then Dr. Funke.
Thank you, Arsham. I'm excited to be moderating and presenting with you three. I think this is the first time we've had us three together, so it's
Yes.
going to be great to see everyone's insight on this. I'm Sahar Bedrood. I practice in Los Angeles. I do everything from MIGS to complex glaucoma stuff. I use iTrack advanced canaloplasty for several years now. Big fan of the light, big fan of the blanching, and even bigger fan of some of the newer things that have kind of developed over the last few months. So happy to share it with you guys, and I will hand it off to Christine to introduce herself as well.
Awesome. I'm Christine. Great to be here too, with two amazing coworkers and friends. I am out of Phoenix, Arizona, and I am a glaucoma trained specialist. I do a lot of interventional glaucoma and then also still do some general cataracts when they are thrown my way. And I've been doing iTrack, oh my gosh, you guys, I think almost like 10 years. So I started with iTrack when we had to self-feed before there was this new development of the handpiece. So this has definitely been a I've been a big fan of iTrack for a very long time. But yeah, I think talking about the pathophysiology and the changes that we can make with canaloplasty is going to be the mainstay of our discussion tonight. And there's some exciting new, again, information which we keep alluding to. So I would say, let's go for it.
Yeah, I love it. I love it. So, just a couple of housekeeping things as we start. First of all, it does have clear indications for use, and this is a real glaucoma procedure. So there are issues that can arise. Although when we're working in the angle, we certainly keep those to a minimum compared to the subconjunctival space. But the other thing about this is, like, we really do want to touch on some of the data that pre-existed iTrack and the physiology of the outflow system and the TM and beyond. And so, what I really want to start with is obviously the late Murray Johnstone. And I think when you look at his work, and certainly have you two chime in, but also the audience, we have questions in the chat that we'll address. And if people are kind of really gunning to like say something, I think we're all learning here. So why not just interject and interrupt? We'd be more than happy to hear you. But Murray Johnstone really probably at the start of his career when he was working with Dr. Grant, and he really started publishing some things on outflow physiology that people weren't super convinced by. And I think as he started to build on his work, this is kind of what has laid the groundwork for our field, even though we kind of jumped into the angle with like stenting before we really understood some of the things that he was saying. So, what I want to first discuss is, maybe throw it to you two. Like, what is it when we talk about like the pressure dependent outflow system and then the pressure independent outflow system? So we got the two ways that they go. And what do you think about that as far as like when the IOP goes up, like what's really kind of going on in the TM and the collector channel system?
Hmm.
I mean, I can take a little stab at this. I think the first answer is we don't entirely know everything, right? We don't know. We don't, but pressure can come in two different ways. You can have that super high pressure where for some reason there is some kind of either non-functioning or collapsed collector channels or plugged up or inflamed for one reason or another. It just basically stops functioning and your IOP shoots up. But I think that the other part of it is that we see plenty of glaucoma at normal-ish pressures, right? That are not super high. And there's definitely some element of of something we don't entirely understand, besides that, because things might look open, things might be flowing, but maybe further down the line. I think one of the pictures that you'll show later on shows you all of the like fine channels that are really a big part of this living pumping system that is not just a passive piece of tissue. And that was really revolutionary. When I saw some of these images, some of these videos of Dr. Johnstone's work, it really changed the way I thought about the anatomy. I didn't go to goniotomy first because of that reason, to be honest with you. I thought that it is a living, functioning, pumping system that functions like a heart. So, you want to stent it, you want to bypass it, you want to clean it out, same as you would, if you're trying to channel the arteries. So those are kind of some of the ways I think about this when I think about glaucoma. How about you, Christine?
Yeah, I'm gonna put myself out there and say that first, when I thought about the angle, especially as a resident, it felt like a very like mysterious place, to be very honest. And maybe some of the mystery is still there, but I thought of it as all passive, right? I thought there was just like fluid flowing into the canal and then through the TM, and the TM was the issue, which is like a sieve that got clogged up, and then there was nothing more to it. I think that Dr. Johnstone's work really helped us open our eyes to understand there's passive transport, there's active transport, and then obviously we have multiple systems working at one time. So it's such a complex component of the eye, and it's so small that we can't even fully understand everything that's happening. But I agree with you, Sahar, which is we want to try and preserve it first. And I think that was the biggest mainstay of a lot of what Murray's teaching was, which was try and fix it. Try and work on what we already have, because it's an elegant system. And if we get it to function better on its own again, well, then we're going to win, right? Longer term. And I actually talked to him personally about goniotomy versus canaloplasty. And he changed my mind that quick, which I said, well, when do you do a goniotomy? And he said nothing to me. And I was like, okay. And I'm like, well, okay. And he said, did you do canaloplasty? Have you cleaned it? Have you tried? And that changed my whole mindset of when I was using a goniotomy versus when I was doing canaloplasty, which was I really flipped to saying, I'm going to try canaloplasty first, with the idea that I want to try and rejuvenate this beautiful architecture that we know is there, and see if we can do it. And I think that also goes back to what we've learned about with all of this stuff, which is the earlier the better, right? So if I'm waiting until everything is stenotic and, just a complete scarred disaster, well, all of this isn't going to work, and this elegant system is already broken. But if we catch it early in disease state, I think we're going to have a lot better chance of doing what Murray told us to do, which is try and fix it. And so when I think about this system, there's just so many components, like Sahar said, we don't understand. And there's so many components that I think we have the ability to help to make function better if we just, again, get to it sooner and be gentle with it.
Yeah, I love that you brought that up, because I think like the disease state, like in a perfect world, we would know who's going to progress and who's not and who's going to have dysfunction. But when you start seeing it early, I've started to kind of flip that way too. I do think that TM needs to be addressed earlier. You're already seeing that in like light study data and SLT. But just to give even a little bit more like physiology background for our audience, if you think about how pressures work in the eye, as you raise that pressure, you're going to have more outflow through the TM up to a certain point. And at some point, you get the pressure high enough to where it actually collapses against the collector channel system. And so if you let that sit for long enough, then it's exactly what you both are alluding to. Like you get more fibrosis in that system, then you get these like almost, I call them exvaginations, where the TM kind of goes into the collector channel system and now it's blocking it. So you've taken a canal and you've collapsed it, and you've collapsed it against these collector channels that now are blocked by a dysfunctional TM. And so one of the things in the side of like, pro canaloplasty is if we can at least get the canal back to open, and some of that internal pressure, I mean, I think maybe we should talk about this a little bit. Like when we raise the pressure in the canal, have you guys observed anything with like sometimes pigmentation that comes back into the anterior chamber? Maybe talk about that.
I have. So, when you're doing canaloplasty, specifically, I will say more with iTrack than I see with other models. I will get a plume of, I call it like the plume of trash, honestly, of like all this junk that's coming into the anterior. I am very technical, guys. But really, I mean, it's just all this stuff that it's so satisfying to see all of this stuff coming into the anterior chamber, which eventually you're going to sweep out when you're doing an IA or cleaning out your anterior chamber. But it's satisfying to understand that you really are breaking down potentially some of the, I don't know, I guess some of the abnormalities to that trabecular meshwork, but also just giving it a good washout. And I think there's a lot to be said to that, especially when we're talking about patients for sure with like pigment dispersion and pseudoexfoliation. Yep. I think we're going to get a really good bang for our buck there. But I think that all patients, there's a component to that. And we also know that for whatever reason, the body starts to ignore the angle and cleaning it out. And as we get older, it just kind of gets more used up. And so I think just kind of giving the body a reminder, whether it's with SLT or with canaloplasty, like, hey, this is an area that needs a little maintenance, I think would hopefully help as well with, again, kind of repairing what was damaged and lost.
I love the funky spa. That's where I'm going to go get my TM cleaned out.
Yeah. Well, it also makes me wonder for you guys, do you ever worry, does it keep you up at night to think about using something like some of the medications we do that actually shut down the trabecular meshwork? Does that further ensue some of this damage, right? So I think about when the majority of us start a prostaglandin first if we're starting something topical, which of course we're all trying to do less and less of. But the reality is that's the majority of patients are still getting prostaglandin first line. Are we actually making a negative impact long-term on the exact place that we're trying to clean? I just wondered if you guys thought that, because again, it does kind of keep me up at night.
Yeah, I mean, look, I think that there is a fine balance, right? Because you have to get the pressure down in a lot of these patients. If we're starting to introduce drops in, it's because their pressure is too high. So yes, there's a safety component, but I think long-term, something changes. I think those prostaglandins, I think the preservatives, I think all of the different chemicals and across the drops can change the structure of the eye, and it can certainly shut down. I mean, we know what it does to the conj and the ocular surface. It's terrible. Let's think about what happens deeper, right? If you're, we were just talking about a case earlier where we're trying to, do a bypass, and it was like, it's difficult to do that in patients who've had such long-term medication use.
Well, and we can even kind of think of it this way, and I'm sure it's happened to you. Like, say you have a patient that you take in and you're doing like an angle procedure, and let's just focus on like blood reflux. Have you had those that are like really, really early, minimal disc changes, maybe like a little pressure elevation? They're like on one or two classes, but nothing's really changed. And you do an angle procedure, and it's just an amazing amount of blood reflux, and you'll even see it in the canal. And I started thinking, I was like, was that really glaucoma versus the patient that has been treated for a while, or maybe even not, and the disease has been going on for a while, but especially like medication treatment, like you just don't see much in the angle sometimes in those cases. And you wonder, that's probably real deal glaucoma. And I don't know if we've made it any better with the medications that we use, to be honest.
It's a wonder though, or were you just hitting that canal when you still had a lot more ability to have like flow? And maybe that's why you're seeing more heme. So I was just thinking about actually a case I did today that I was placing some stents and I got a lot of beautiful heme. And I had a student with me. I'm like, that's a good sign. But you're right. Sometimes with more advanced disease, you see nothing, even though you're in the canal. So it's a good question we don't know the answer to, I think.
Yeah, and I think to your point, like the medications do limit like our outflow over time. And like the more that you pour them on there, like the episcleral vessels and the collector channels are literally like right underneath the surface. So there's one hit. And then the atrophy from disuse, like look at what happens post trabeculectomy if you have a good pressure, right? Like if you get like a nice low pressure and now your pressure dependent system, it's not really moving fluid through that area. When you go back and you try to open it, like it just doesn't work that well versus like a trab that didn't do so great, which means that they're still relying on their TM pathway. That TM might be a little bit more amenable to functioning. And similar to like a traumatic cleft, like a cyclodialysis cleft. When it's too low, that attrition or disuse, I think that's how things start to scar up over time.
Yeah, and then when you see that cleft close, the pressure of pre-cleft, of even if it was like a 30, say, post-cleft closure, the pressure goes to 70. Well, why? I think it's because you now have no pathway, right, of either conventional or unconventional, and now everything's shut down. And so again, it makes me worried if we're choosing not to work on the TM, et cetera, especially early. Am I like giving up on it and actually letting it get worse over time because I think I'm actually doing a better job with it? So I don't know.
Yeah, no, I'm with you. And just to like start to orient people, this is the sclera. I don't know if people can see my mouse sclera, but the intrascleral collector channel system here. And then like here you have TM is TM and the anterior chamber. So things flow into this area, and the deep scleral plexus that we have that kind of routes fluid into the intrascleral collector channels, ultimately going back to the episcleral veins. This is our entire outflow system. And I think initially we really focused a lot on just the TM portion of it. And I think that's what was easily accessed. And the common thing is like the juxtacanalicular portion, right? That's the site of the resistance. But like you take off the TM and you remove that site of resistance, like you still get people that do not have great pressure responses. Why do you think that is? And what is it that maybe we should be doing more of in those cases?
I mean, let's take a moment to appreciate the beauty of this anatomy.
Mhm.
I used to do electron microscopy ages ago during my PhD years, and I can appreciate this. But look at the TM. It's basically an array of sponge-like material, right?
Mhm.
And it is creating resistance first and foremost, so that it
Mhm.
takes effort for that aqueous to get through there. And you can see it's different along the different parts of the TM, in fact. And then once it gets through, it just kind of then channels everything over. And you have patients, think about all the disease processes, your uveitic patients, your pseudo-X patients, your pigment dispersion, all that's going to be completely full, right? And then there's no flow through there and you have a collapse. I think a lot of this has to do with chronic collapse, scarring down, disuse, misuse, whatever you want to call it. And I think the ability to early in the disease process open this up, revive it, and let it kind of function a little bit. I oftentimes will take patients off of drops, all of their drops, because
Mhm.
I want that aqueous to push through. I want it to be fun. I don't want to put them back on a beta blocker or anything like that. I just want it to push through and keep that going. And oftentimes I will see the results of my canaloplasty 2 or 3 months later, much better
Mhm.
even than
Mhm.
post-op day one or post-op week one. But like, I appreciate this anatomy because it
Mhm.
explains so much about how aqueous flows.
Yeah, and if you look like the study I was alluding to with like Robert Moses and the invaginations with like increased pressure, Hyun Gong out of Singapore, she's looked at that a little bit deeper. And essentially, what happens is when the pressure goes up, these invaginations they lodge into the canal, and it's the blockage of the collector channels at that canal portion that really result in that drive and IOP elevation. And so that's kind of where I started thinking, like, yeah, I mean, maybe there is something to be said about like viscodilation alone to at least pop those things out and get your collector channel openings open again, because that's a huge part of why we sometimes have failures with even things like SLT. Like SLT is not going to change that. Like pop the invagination out. This is like truly like a surgical thing. Maybe talk a little bit about how like the segmentation of the canal, like how does that impact the work that we do, goniotomy, stenting to like these catheter-based devices?
You mean like the segmentation from TM on, that we have all these different areas that we need to try and hit at one time? I mean,
Yeah,
I
I
think
think that,
that's
yeah.
kind of the key of all. That's like the beauty of this system that we're talking about here with working in canaloplasty, and especially with iTrack, is that we have more penetration into these other portions of tissue that we don't have otherwise, right? So if we're bypassing with a stent, great for the trabecular meshwork, that we're getting around that component, but we're really not hitting downstream. So as we start to look at all the different problems, we don't have a really good way of diagnosing where the problem is.
Mhm.
So this is going to be an option that's going to hit multiple places at one time and 360 degrees around. That's one of the reasons I love doing canaloplasty, and especially what I would consider aggressive canaloplasty. And by that, I mean a lot of viscodilation. I think it's going to give me my best chance of getting to all the tissues that have the potential problem. And we all don't want to go into an eye with anything other than success surgically, right? I think that's one of the hesitancies a lot of us have in terms of doing standalone MIGS. And this may be something that will help people overcome that, which is saying you're hitting multiple points of resistance and multiple problems with one fell swoop.
And I think like the other thing to understand is like, if you just do like a partial goniotomy or you have like a stent, this is not going to direct flow 360 degrees. The only way to really get that is to catheterize it because Schlemm's, it's going to have those segmental portions, not like a hula hoop. And I think that's another portion of like a catheter-based device. When you said, Christine, like you said, aggressive viscodilation, like I think it would be useful for people to hear a little bit about maybe like your technique, even though that's not the whole point of like what we're going to discuss. What does that mean?
So for me, first off, I like to hit 360 degrees. If I can clean the entire collector channel or the entire channel, I want to. So that's kind of my goal one, whether that means I can only get the catheter, say 180 degrees and I have to go backwards. I don't like leaving any of this area untouched because we just don't know where the disease is really sitting. And that's on us diagnostically. We just don't have that information yet. So I just assume if I'm there, I want to hit everything I can. And then when it comes to actual like aggressive viscodilation, what that means for me is I really want to push a lot of thicker fluid in through the canal and then through the trabecular meshwork, hopefully fracturing some of the trabecular meshwork, and then also getting it through the collector channels and downstream. Because I think that that's going to, again, give us our best bang for our buck, which is, again, all of this area. Because we just don't know where within 360 degrees I'm having a problem. And I also don't know what layer of all of these different tissues, if not multiple, I'm having problems. So I say aggressive in a good way, which just means I really want to hit as much as I can.
So how many clicks are you going like per quadrant?
I'm trying to get around 40. And there was some really good data looking at some of the amount of viscodilation or how many clicks you want to get in. So it's about like 10 per quad. And that was looked at by Shamal Patel. He was the one who kind of looked at some was too little and some was too much and trying to find the sweet spot that gave the best amount of IOP lowering at the end. And that was about it, between 40 to 50 clicks.
Yep. And then, so can we like maybe talk a little bit about, and we alluded to this, Sahar, maybe touch on why like goniotomy might potentially ruin some of this like pump mechanism and how it works and why viscodilation might actually leave some of that intact.
Yeah, so I think one of the main parts of his work was showing that there are tiny little structures that hold the canal together, and it's all attached in this pumping mechanism that allows it to literally, I mean, if we had the video, we could have shown it, but it literally pumps it like a heart, honestly, to the collector channels. And one of the things that I liked seeing about that is that if we can try to keep it as intact as possible, then maybe we can preserve it and not ruin it. Now, when you do goniotomy, in my opinion, I don't like to do it as first line for an angle surgery because you're in one fell swoop ripping it out. You're unroofing it and you're getting rid of that kind of pumping action. Now, sometimes patients need that. If it is completely clogged and the TM is not working, or you have, this like really bad uveitic patient where everything is just kind of, contracted and fibrosed, then yes, let's remove it. Because even if you clean out beyond it, your TM is not working very well. So in those cases, after I've tried other things, if it's still not working, I will unroof it. But I think the goniotomy, allows, you see whenever you do a goniotomy, you'll see the white sheen of the scleral right behind the TM, and that is great when you see it, but you've taken out that pumping action. So for me, I do like to preserve it. I do want to use that later when there is always a place for all of these different angle surgeries, but especially early in disease process. And we did actually have a question from the audience that talked about here. This says something about lab studies showing BAK causing apoptosis in eye tissues. And do you advocate for considering canaloplasty early in the course? And it is, yes, it is. It's exactly that, so that we can proactively go in and intervene early on in the process. That way we preserve. And then, yes, maybe they need a goniotomy a couple years later. Maybe they need a bypass stent. Maybe they need a subconch blood surgery. But being able to kind of allow the natural structure to function, that's what I would want, right? If I needed a surgery, I'd be like, can we use what I have already, see if it works, do it early in the disease process, and then next steps if we need to down the line.
And then, so maybe Christina, getting text from questions from like viewers, like how much is too much OVD? Well, is there a point at which and is there a chance that we could traumatize some of these
Of course.
pump mechanisms?
Done it. So, there's always the potential for having endothelial cell detachment. And I think that's one's too much. Is it repairable? Yes. Is it a pretty simple repair to do when and if that happens? Yes. Is it happen frequently? No. I think a lot of times that actually, when it does happen, there's probably some sort of abnormality to the endothelium where it actually connects into the TM, because I usually tend to do about the same amount of OVD for each patient. But yeah, you don't want to be overly aggressive with this. So we've already done the legwork for you guys. So about 40 clicks is good, maybe 30 to 40.
And which viscoelastic are you using?
I'm using ProVisc. That's my favorite. And, nothing that's too heavy. And we have to talk about shearing too, but we want to make sure that we're using the correct OVD for that as well. But yeah, I think we want to try and get a good amount in there, but we don't want to make any complications.
I love it. And this is kind of like where we're going to allude to. I mean, we'll touch on this. I don't think this is like anything that's super novel. Like the more advanced disease you get, the less your collector channel outflow is. And whether that is going directly into Schlemm's canal to measure this or going from the anterior chamber through TM, your collector channels, I mean, you can see like where the flow is. It's very, very minimal in more advanced disease. And I would even call not so much advanced disease, but chronic disease. Like your cup to disc or your field might be okay-ish, but the longer you've had the disease, the more likely it is that you've had this atrophy. So let's jump to like what you see clinically or surgically now. Describe like the difference between a fluid wave and the blanching that occurs with like viscoelastic with the iTrack system.
I can jump in on that one because I love being able to see blanching. So blanching basically is when we are starting to place the viscoelastic into the canal that you're going to actually see all of the vessels on top of the scleral start to basically go white. Usually when I see that, I usually get a good couple clock hours into canaloplasty prior to starting to see that blanching happen. The majority of it being kind of right underneath where my incisions are. And usually it's after my catheter is already past that area. That's when I start to see the blanching happen. And I think it's super satisfying more than anything because one, I know I'm hitting the right places. I know I'm probably getting downstream. It's a lot of confirmation as a surgeon that you're doing the right things of getting into this system.
Is that universal for all of like the ab internal canaloplasty procedures that we do, or is it more specific to here?
Yes, this is really very specific to this device. Occasionally, I will see some form of blanching with other canaloplasty devices because I'm lucky enough to be able to try all of them in some capacity, but I feel like I get the most blanching by far and away and consistently with an iTrack, yeah.
Sahar, what about you?
Yeah, I think that's, early on that was the one thing that we noticed. And I think there's a picture of it between the pre and the post, if you want to pull up that slide. But they're basically, as you're going in, the second after actually a few clicks of the viscodilation to come out, it starts to get white. And it is so satisfying to see. First of all, it gives you this sense of like, I'm doing something here, something is changing in this anatomy that has not changed in years for this patient. And you push things through and you know that hopefully you're cleaning it out, which, as Christine says, the junk, the trash, you're getting that out. I never thought of it that way, to be honest with you.
You're just sending it right back into your own cardiovascular system, though. It's recycling.
It's our own stuff anyways. But I think being able to see that is A, satisfying, B, it kind of just gives you this impression of like, okay, we are pumping some life back into this. Now, I will say you have on occasion patients where this does not work.
Mm-hmm.
And that is usually in an advanced patient that is like has nothing left, but you're trying to, do this for the patient. So I will say there is really an advantage in a less advanced eye. I think that this goes further for that patient.
And just to kind of like round things out too, so that fluid wave that Grover described was looking at after you've done a GAT. So now you've taken TM off and you do IA, or you pressurize the system. They were measuring how many clock hours they saw this fluid wave or some of the blanching. It actually is very different than the viscoelastic blanching that you see before you've removed any TM, and maybe you don't remove any TM. The blanching with the viscoelastic seems to be a little bit deeper and further downstream.
Mm-hmm.
But what they did was when they took the TM off, the trabecular meshwork off, and they pressurized the system, there would be blanching of the fluid or the aqueous or the BSS technically that was going through there. And that correlated to IOP reductions and med reductions until you got to about 4 to 6 clock hours. And so, yeah, if you're like a GAT person and you take the TM off, you'll be able to get fluid flushing through that system. But what's different about the OVD is, especially in this system, it's the shear. And so maybe I'll have you guys discuss a little bit about what happens to these cohesive viscoelastics when we put them under pressure, especially in the system going through like a really small channel.
Yeah, I think one of the things that we've learned about recently, and I think one of the main points of this webinar, to be honest with you, is looking at the difference. You see here, you pick up that, and it looks like it is almost like water, right?
Mm-hmm.
It is thin. It is almost stringy, linear in appearance. But if you look at the OVD on the left, and hopefully, look at the timing of that.
Perfect.
You'll see here.
Perfect.
It's more like a blob. Look, you don't even have those, like, it's not like water. This is like a gel that is stuck together. And the other side is like almost like water. Even the droplet looks like water. So there is a difference that happens. And what we are alluding to is this shearing, this shearing that happens when you send the viscoelastic through both the viscodilator and the catheter and the microcatheter. And what it is we are thinking that it is this huge amount of force that is changing the way that viscoelastic material, it's going from a blob of molecules to a linear kind of almost water.
Mm-hmm. And this is really important because I got another text about like the TM is like a one-way valve. And that's really what Marie was showing, that it is truly a one-way valve. And why would that be the case? Well, if the TM was like able to like move things back into the aqueous, like you lose your blood aqueous barrier. I mean, that's literally part of it. And in fact, when you have really bad hypotony, so the IOP is really low, and now your episcleral venous pressure is higher, well, you're just going to continue to get blood refluxing into the anterior chamber. And sometimes that happens, but the whole point of the TM shutting down is to prevent that blood reflux back. So you preserve that blood aqueous barrier. And the valve mechanism, you want something that's more in a liquid state, not as viscous, for it to be able to move through there, but also to try to prevent it from getting damaged, because it's fluid moving through there, not a highly viscous fluid, but a low viscosity fluid. And I think that's where the shearing comes into play. Christine, can you maybe like talk a little bit about what it is that turns the viscoelastic from what Sahar was describing to this like liquidy looking thing to the clumpy thing? Like, what's the difference between those two?
So just to let you guys out there know, this is the same viscoelastic. I don't know if we made that clear enough, which is this is the exact same thing. On your left, this is like if you took it and just squeezed it right out of the tube and put it on your mayo tray, this is what it looks like, clumpy and thick. And that's because the like natural state of viscoelastic is like a ball of spaghetti or a ball of yarn that's all just jangled up. So it's fluffy or thick or gloopy. And then the right side is actually when the viscoelastic was already put through the iTrack and then squirted through the end of the iTrack at the end of the catheter onto the Mayo tray here. And then that becomes very thin and watery. And what's happening is, and this is what's very different from the iTrack versus other systems, is that you're actually putting it through multiple steps of turbulent flow. Those multiple steps of turbulent flow with each step, and you need about 50. That's why we need to prime this in the first place, and why we need help with somebody else kind of doing the clicks forward, is what it's doing is it's pushing a lot of pressure and turbulent flow, creating the change molecularly from this balled up tangle of yarn to very straight molecules. And it's just for a small period of time, right? And that's the time when you're actually pushing the viscoelastic into the canal and then downstream. And we're thinking that the amount of pressure mixed with this change molecularly is what's making us have more blanching, which means more downstream access. And that's different than other technology that we have, which they're coining as shear clear. But basically what that means is we are changing the molecular viscosity and the amount of pressure going into the system enough so that we're getting access to as much of the collector channels as we can. And then also obviously opening up the canal and then cleaning out all the gunk of the TM. So we're really hitting a lot of different places. And this is why I think we're all thinking we're getting so much blanching with this system versus other systems. It's because of the change molecularly. And then the coolest part too is that the shearing doesn't stay that way. So the video that we looked at, that thin, the thin stringy viscoelastic will change back into the more clumped form. And I think that's why when we do this form of canaloplasty, it takes about a clock hour or two until you start to see the full blanching. I think that's probably when you're starting to see the molecular change back to the clumpy form. And then everything balls up and then everything gets kind of just clogged up for a moment and everything starts to really get pushed open and dilated, which is just what we want. And then if you keep watching it, eventually you lose the blanching, right? Within the end of the case, you usually see all of the blood flowing back into that area, which is good because we don't want it just sitting there either, or else we could have, another pressure problem postoperatively. But that's kind of what's happening here. And I think which is what makes the iTrack such a unique system is we're learning more and more about the positive impact of having kind of like a multimodal system happening at the same time here.
Yeah, and I'm glad you brought this up, Christine, and I kind of left this on purpose. For me, I was annoyed about here's the second thing that I got to hand off to like my scrub and they're dealing with it or whatever. And that's really kind of part of the strength of the system is because it's able to build pressure and put it through a very small column. And like you described, you get this turbulent flow. And maybe that's like the little diagram here, but you end up having this kind of ball of spaghetti that ends up turning into more linear strands of the viscoelastic chains in order to get further downstream into it. So what we thought was annoying was actually it's just a positive suit for this device. So let's see here, and I think this is kind of what we were talking about a little bit about what things look like before and after in the blanching. And when you see the fluid wave, I think it still looks different than this. The fluid wave ends up you still have like some of these vessels that you can still see. Like with this, like things really blanch out like uniformly across the sclera. And so I think these are some of your pictures, right?
Yes. Yeah.
Yeah. Do you want to describe them?
Yeah. So basically, this is a picture right before I was going to do the cataract as well for this patient. But this picture on the top shows this kind of subtle. I mean, this is not like a hugely red, horrible, advanced disease eye. This is like an average looking eye. And I think that's the value of this photo. You see the small vessels, and then I did the iTrack canaloplasty, and you see this whiteness, this all around the limbus, about 3 or 4 millimeters past the limbus it can go, and you just see all of those vessels kind of disappear for a moment. Right? They have now either opened up collector channels, something has shifted and pushed things out past the TM past the collector channels and has definitely changed the way the anatomy is. And it is really is universal. I see it on almost every single case, unless it's so red that like I can't see past the conj in those patients. But I think that these were early on. We noticed it, so you notice that something is different about these patients, and I think that is useful. It's speaking to, as surgeons, we like to see the light. We like to see things go all the way around. We like to see a result from our surgery to kind of tell us that something may be working. So those are some of my pictures that we share.
I think it's super helpful. And like the people that have been using it, maybe people that have not been using iTrack, like, I mean, there are some modifications in the injector system that allow for more of this shear thinning to allow the viscoelastic to go deeper. And it was something that I think Christine like really described well, but it's great to see it visually, right? And for me, I didn't like really believe it. I remember like kind of talking to Joe, who's been very involved in this, and I was like, like I just want to see it, that video demonstration of low viscosity, high viscosity with the same OVD. And when they showed that, I was like, all right, I'm convinced. Like you spit this out of the iTrack, it looks way more like a fluid-like state than the clumpy-like state when it just comes straight out of the cannula. So, but a really nice representation, Christine. Like you see these balls that are not really lined up. They're kind of like a thing of spaghetti, and then they turn into linear lines. And it takes maybe like a minute or two for this to kind of clump back into each other, which is what you described. We're getting kind of close to wrapping up here. So maybe we talk a little bit about like how that delivery happens. You described that, like when you're going to see the blanching and then when it goes away. Is there value in letting that sit? Is it just a part of the case, like letting the viscoelastic kind of clump back? And I was kind of wondering, like, does it actually dilate downstream a little bit as it turns back into that kind of original form? Because if you look at the two blobs, like the really viscous one seems to have like a better form to it than the one that looks more watery. Like, is there any benefit in waiting after you inject the OVD in?
I'm going to chime in because I don't. First of all, I don't know if any of us know the answer to this, but I'm going to give a theory, and I think it's like if you take like an esophagus, okay, and you have food going down. An esophagus and a canal are basically the same kind of tissue, right? An esophagus is flat when it's not being used. There's, you're not eating, nothing's going down there, and it's like if you drink water and you have that really shear thinning, it goes straight through, opens things up. But if you have a clump of, I don't know, like a piece of bread or like a meat that's like just clumpy, that is going to take a lot of time to go through and maybe not fully open things. And then it might collapse right back. So I think this shear thinning is actually allowing like some forceful gelatinous, but almost liquid, to go in there and open it up. I think that's the difference because there's clearly a difference between this and other surgeries that we do in the canal. So that's my theory, and I'm gonna stick with that theory. And I also
love it.
That's probably why you don't have IOP spikes, right? Because like, how is it that if you leave a little bit of viscoelastic after a cataract, you're gonna get an IOP spike because it's a clump, right? Whereas if you do this, you don't. It lowers the pressure, so you're opening it. There's just these nuanced differences that we see in different surgeries, and we can actually kind of explain it now.
I do think, Arsham, you have a point too. I think you're trying to allude to the fact that, like, okay, then once it's thin, it's going to go also back to clumpy. And I think when it goes back to clumpy, we're going to get even more dilation than we would if we just very slowly kind of snail tracked in there with some viscoelastic. I think that's got to be, and we don't know, right? Again, this is all theoretical at this point, but I do think that there is part and parcel to that as well, of saying like, we're going to get further downstream, like Sahar said. I think we're going to hit a lot more anatomy this way, but then also afterwards, I think letting it go back to its natural state probably even behooves us more, because then you're going to get more dilation in all the places that we have loss of, opening, whether it's the collector channels, whether it's the main canal itself. So
yeah, and I look at this and I'm like, I mean, there is a reason why sometimes like patience is virtue in some of the surgeries we do. I'm like, yeah, we kind of will let it sit in there and see if it gets back to clump form, because we're pretty far downstream, right, before it gets to that. So as we kind of wrap up, like maybe some closing thoughts, what would be like, what do you wish that we could do to like optimize some of these angle procedures? Is there's like something that you wish that we had, and maybe we'll get there eventually. Because right now I think we're finding a way to get really downstream into some very micro channels, right? Which we did not have access to before. What's like the next step?
I think we need to back up and understand a little bit more of probably what we're doing before we do it.
Mhm.
Again, I think we're still a little woefully behind in understanding when we need to intervene and where we need to intervene. I mean, that's what's nice about canaloplasty. At least you're kind of hedging your bets.
I think
So, I
that's
mean,
so critical, Christine. Like, if we could identify the slides, like that'd be amazing. Like the collector channels that are collapsed. But with this, you're pretty much hitting everything without stripping stuff off and worrying about these like large hyphemas.
mhm. I also think what would be nice is I like to think about like synergy between different mechanisms of device. So I do really believe, and I think this was one of the things in the chat, which is, are you just doing canaloplasty? A lot of times if I can do more than one thing, I'll do canaloplasty with drug-eluting stents. I will do canaloplasty with stenting. I mean, I don't think I have not been sad to do multiple devices on anyone. I think the risks of these things are so small. And I do think that there is, again, a way that we can stack different devices that they're each helping each other because they're each doing something different. So I think the only other thing is, I mean, we need to have more support, whether it's evidence-based support, retrospective review of all of our own data to really help keep what we have around so we don't lose it to a lack of evidence.
Yeah, and I think I was just getting some updates too. Like the amount of time that it takes to kind of recall it back is about 20 seconds. So it's not like you're sitting there like staring at it forever. But I think as we're working through the case, like it does have that opportunity to rebound back and hopefully even like dilate those more distal vessels. Any other kind of closing thoughts and maybe like questions? I've been getting texted questions. I don't know if people want to like chime in and share their thoughts, but I do think it's something that for me, like I've personally changed a little bit. Like we do more of this very specifically with iTrack. And some of this is really based on theory and now a little bit more theory evidence building up to pressurize the system more downstream. So it's been something we've been using a little bit more.
I think what we're going to end up finding over time is, and hopefully this is what we do, is identifying the patients where these different things work best in and why, right? Like, yes, maybe some people have no collector channels left. All right, well, that's good information. I think as we get to do these and more patients, get more evidence, more data, more technology, even this, looking at the difference in the viscoelastic quality is changing the way we're thinking about this and maybe changing the way that we will decide to do it on certain patients. So that we're not doing this shotgun approach, like everybody gets this and everybody gets that. No, like some patients will do really well with this kind of procedure. And it's not even going to be surgeon dependent. It's going to be a known thing. I think that will probably kind of change and evolve over time in the next, hopefully a few years.
And then just a couple of chat questions very quickly. Do you do a goniotomy or how much with it with a canaloplasty if it's more mild to moderate glaucoma, or do you stick to just canaloplasty?
I'm trying to stick to canaloplasty, at least first.
Hmm.
I think it's just worth seeing what it does for us. And there's great data supporting that this is a really effective first line therapy or early therapy. So give it a chance.
Yeah, I'm curious about it as well, Arsham. I've always been, but even before when we had combined procedures being reimbursed, I was still pretty purist. I'd like to do one thing and see how it does for a patient, and if that doesn't work, then do the next thing.
And just for people as you're starting to dig into some of the literature, because there's been some questions about like comparing with other devices. Not really like our goal here, to be honest. There's not like great head-to-head studies with different devices, but if you look at the literature, like specific to iTrack, that's probably got the largest pool of canaloplasty data only, not combined with like goniotomy to kind of confound things. So there is like a note, I think American Journal of Ophthalmology or one of those like larger journals has the most recent like 12-month data showing canaloplasty ab interno with iTrack specifically, and you can really kind of tease out some of those numbers. So the comparisons we're not going to make because there's nothing like truly head to head. But when you look at the data, this is way more canaloplasty driven than canaloplasty plus goniotomy, which is a lot of what you'll see. And then maybe one final question, because I think this is something that we all kind of think about and talk about in the venous system, and it's coming from the audience. Why do you think trabecular meshwork stays open after canaloplasty? If it were collapsed before temporary dilation, will it not change will it change its structure? What are your thoughts on that? Like, so why doesn't it go back to being collapsed if it was collapsed originally?
I mean, personally, I do worry that this is transient effect. How long, though, I don't know. And again, how early we work on it, I think we have a better chance of potential remodeling happening. But I mean, everything that we do with glaucoma has an end date. But I do still believe that you have the opportunity to do a lot of potential good. But I mean, I think it's glaucoma. It's going to continue to want to go back to a glaucomatous state, whether it's anything that you do in the canal or external to the canal, right? Everything we do has unfortunately a time where it's not doing enough.
And maybe I'll address this because I've kind of been like pretty public about like, on the venous side, like you get collapsed, like how does it not go back there? Well, at least in Schlemm's canal though, and if we kind of look back at like what we were talking about, you raise the pressure and you collapse the canal. Well, that's why AC taps can work in like POAC patients. You decompress it, there's fluid back in the canal, and it has a tendency to stay open for a little bit. Is it permanent? Not necessarily, but if you can get those like invaginations popped out and you do open it, and now you have a little bit more outflow through the TM, the fluid there, just like the fluid in the subconjunctival space keeping your bleb alive, the fluid in the canal is actually what's now holding it open. Your job is to try to get it open, maybe reverse flush some of the things that are blocking the TM, and then hopefully after that, the fluid is actually what's keeping it open downstream. So just kind of my thoughts there.
I agree with
also,
you.
Sorry, Sahar. Go ahead.
I was saying that, I've thought about this because I'm like, well, what's the point? If it's just going to go back to where it was, like, why are we doing this? But that's kind of my, after surgery, I'll take them off all their drops because I want that push. I want the aqueous to go in there. So that's one of my methods. And I have found that helps me. Obviously, I will restart some of them if I need to, but I don't want high pressures. But I do think like that's right, Arsham, you hit on it. It's the aqueous. If it's early enough and it's not scarred down and we've revived it, then it's the flow, the natural flow that it was originally meant to be, that's keeping things open.
And also, I've gone back and done a canaloplasty again. If I've had somebody who's had success for like multiple years, and then I start to see a pressure rise, there's nothing wrong with going back. It's just like an SLT repeat.
Yep.
And so again, if you're starting to head back towards the natural state, or again, we don't even know if that's true, right? It may just be the natural progression of disease. So we like to blame ourselves for everything. When something is going wrong with glaucoma, we immediately say, oh, it's whatever I did. No, it's not. It's also, this is a chronic progressive disease. So if that's the case and you have progression for whatever reason, which we don't know because we don't have the diagnostics to support it, then you can go back and clean it again. And I think that's a great option, especially if you got, again, many years out of a canaloplasty.
Yep. Listen, this was really good. It was great to kind of, I mean, we always do like these surgical talks, but like the theory behind the surgeries that we do, I think is actually like probably even a little bit more important. And I really, really appreciate talking to you guys. It's so much fun, learned tons. So thank you so much.
Thanks for leading us.
That was amazing. Right. Yes, thank you. Thank you for moderating.
Oh, it was great. Good to see you.
A thinker. I love it. That's why I always like you on any presentation I do.
No, I love talking to you both. It's honestly like so enjoyable. I think we all learn a lot, and hopefully our audience did too. But thanks so much for your time this evening, everyone.
Thanks, you guys.
Bye, everybody. Thank you.
Bye.